And over to Jessica, who's a final year clinical haematologist and laboratory haematology advanced trainee, keen on cell therapies, management of acute leukemias. Interests, there's no infection there again. Come on. Again, I remain fascinated that people find anything else interesting, but I'll take that on notice. Thank you very much for coming along, Jessica. Sorry that it was a bit late.
Yep, no worries. Thank you for the opportunity to speak today. So I'll be presenting a very spectacular case of CAR T cell related complications in a very heavily pre-treated patient. So just to introduce the patient relative to our case, when we first met her in April of 2020, she was 47 years old, not too much in the way of background medical history, presented to a peripheral hospital with abdominal pain and shortness of breath, hepatosplenomegaly ascites, an adrenal mass, and a right iliac fossa mass on imaging, and proceeded to have a laparoscopic biopsy of that mass in the lower abdomen. So FDG PET imaging demonstrated the same areas, particularly that right iliac fossa mass and the adrenal on the left side to be avid. That biopsy demonstrated a high-grade B-cell lymphoma with a MYC rearrangement, which would make us more worried about the disease. Although the CNS was not involved in this case, just due to the nature of having adrenal disease, we are more worried that these patients have a higher risk of CNS relapse, which becomes relative to the case as we move forward. So just to demonstrate the heavy pre-treatment of this patient before eventually proceeding to CAR T cell therapy, old and faithful R-CHOP was commenced first, followed by 2 cycles of high-dose methotrexate for CNS prophylaxis, mainly due to that concern with the adrenal nature of disease. And she achieved her first complete response from this cycle. Within 12 months, unfortunately, she had isolated CNS relapse of her large cell lymphoma, had CNS-directed therapy with 3 cycles of IVAC, followed by a consolidative autograft, and achieved her second complete metabolic response. Again, had a slightly later relapse 2 years later with isolated bone marrow disease, had 2 cycles of bridging gemcitabine and oxaliplatin as a bridge to CAR T cell therapy. Notably, during this patient's journey, she did only have 2 episodes of E. coli bacteremia during her chemotherapy, which were due to a urinary source, never had any multi-resistant organisms cultured. So just to touch on her CAR T cell journey, she had as standard fludarabine and cyclophosphamide lymphodepletion, and she had the CD19 targeting axi-cell therapy in May of 2023, so almost exactly a year ago to the day. Thank you to Dr. Pereira for explaining some of our acronyms, which become relevant to this case. So she did have cytokine release early on day 4, needing 2 doses of tocilizumab as per our protocol. Did also have neurotoxicity with ICANS at day 6. She commenced on dexamethasone 10 milligrams 4 times a day with a rapid wean over 8 days through to day 14, which was her day of discharge. Concurrently, during these times of fevers during the CRS, patients are often neutropenic, so they do need to be managed as per our febrile neutropenic protocol as well. So she was covered with tazocin. At time of discharge, she was on Valtrex and Bactrim for prophylaxis. Unfortunately, though, within 24 hours, our patient had repeat neurotoxicity symptoms, so was rapidly readmitted and re-escalated onto high-dose dexamethasone with a plan for a slower taper over a 5-week period. After an additional 6 days in hospital, she was discharged again with the addition of posaconazole to her prophylactic regimen due to recurrent neutropenia. Right on cue, after the first month, had a dramatic representation to the same regional hospital, which we met her through, presenting with fever, hypoxia, and phancomopsis, rapidly requiring intubation and admission to ICU. She had a necrotizing pneumonic process on CT imaging, which I'll show you, in addition to pulmonary hemorrhage. Notably, she remained on dexamethasone 4 milligrams at the time of this representation. She also had a rapid rise in liver function and ferritin at the same time as this presentation. And it's hard to work out in these cases whether pictures similar to HLH are being driven by the infection itself, or is it the rare complication of immune effector cell hemophagocytic lymphohistiocytosis? So this was covered with dexamethasone with the addition of anakinra, just in case this was IEC HLH. This is just her CT imaging shortly after presentation. And this is just a demonstration of the degree of cytopenia she had on her peripheral blood counts, very marked neutropenia. She was comfortably over 1 consistently at time of previous discharge. She'd only had a ferritin of about 600 or 700 during her initial presentation, and the liver function derangement was new. So Pseudomonas was isolated very rapidly from her peripheral blood at time of initial presentation with that mnemonic process, and had multiple bronchoscopies during her presentation. She was initially treated with piperacillin tazobactam, but unfortunately with repeat cultures and persisting respiratory symptoms, was demonstrated that she had resistance, which escalated a change to meropenem. After several more weeks of therapy, she did also develop carbapenem resistance, so was escalated to ceftolozane and tazobactam at that point. Also developed pulmonary aspergillosis whilst on posaconazole prophylaxis. After a short period of ambisome, she was enrolled onto the OASIS trial, and to this day continues on the alorifim cover. So due to these complications after day 30 relating to her CAR T-cell therapy, our patient spent a total of 84 days cumulatively in hospital after her initial admission, including a total of 7 days in the intensive care unit. Just to highlight the other complications that necessitate our patient to come in and out of hospital is that she did have periods of CMV reactivation necessitating the use of valganciclovir. She had an episode of feces bacteremia, a repeat admission with parainfluenza, then another repeat admission with acute sinusitis. Other complications mainly surrounding her initial admission where she was admitted to ICU. She did have a critical illness cardiomyopathy with an EF dropping to about 30%, which thankfully recovered since. Persisting issues with thrombocytopenia, delirium, and a significant physical deconditioning in a 50-year-old woman who'd previously been quite functionally well. But not all doom and gloom. Good news is that now 12 months post her CAR, she is in a complete metabolic remission, which is her CR3 for her, and she's thankfully remained an outpatient for 6 months now, despite these many initial hurdles. You can see what she remains on now for prophylaxis, but as you can see from her lymphocyte subset, she is completely aplastic of B cells, and as you'd expect, hypogammaglobulinemic, so she is covered monthly with intravenous immunoglobulin since. So just to highlight some of our learning points from this case, as Dr. Pereira mentioned, we can risk stratify expected hematologic toxicities coming into CAR T-cell, and this patient did have a raised ferritin CRP, thrombocytopenia, particularly coming in to the case, and we did demonstrate those prolonged periods of cytopenias, which we suspect would contribute to her infectious risk. Also with our patients in these scenarios, just to keep in mind that the CAR T-cell is one therapy, but they're also very heavily treated in terms of chemoimmunotherapy coming into the picture as well. I guess reflecting back as well, with the recurrent ICANS, it is per our protocol to be using high doses of dexamethasone to resolve the neurotoxicity. However, in hindsight, it would have been safer to perform a more rapid wean is something to consider, and definitely something we'll be thinking forward in other cases. And just a final point, it's probably almost impossible to differentiate, but just considering whether these episodes of cytopenias, raised ferritin liver function derangement are being driven by HLH related to infection or due to the CAR T-cell therapy itself. Okay, and that's the case. Thank you.